So, hello, Ruta. Can you join me?
Hello.
And proceed with this?
Okay, so hello to everybody. I will talk about prostate MRI, and my talk is orientated both to radiologists, urologists, just to understand how we use prostate MRI and how we score it and what's important to know. So talking about prostate MRI, it has been performed since 1980. Firstly, it was performed for cancer staging, and later on, from 2012, PIRADS were introduced into practice. It is arranged the same like BIRADS that were firstly implemented into clinic. So it is prostate imaging, reporting, and data system. And now we are using the version of 2.1. It's dated on 2019. The latest update. So what does it mean, multiparametric MRI? It means that we are making several sequences that we need for evaluation. It's T2 diffusion weighted with ADC map and contrast enhanced images. What is really important is to make a high quality exam, and we have evacuate rectum prior MRI exam, evacuate gas. It is recommended to use a gas tube, but not all technologists are performing this procedure. And here I want to show you the exam of poor quality, and good radiologists must understand that we have poor quality exam, and here you can see prostate and poor quality exam and good quality one. The same with diffusion. We have a bright lesion in the peripheral zone, and it's seen better in good quality exam. I will remember prostate zone anatomy because it's really crucial in PIRADS evaluation. So we have here we have a schematic picture of prostate. In the upper part we have basis. Here we have apex and urethra going through the prostate. Around ejaculatory ducts we have central zone. In the central part surrounding urethra, there is transition zone, and normally glandular tissue is in the periphery, in peripheral zone surrounding the transition zone. In the anterior part, we have fibromuscular stroma. Usually it doesn't have any glandular tissue. And these tissues we can see also in prostate images. Here we can see the axial images in which in these images we have the main diagnostic work in these axial views or transversal scans. So here we see urethra. Around we see periurethral tissue, transition zone, central zone around ejaculatory ducts, and the peripheral zone surrounding the tissue. And here you can see images of different prostate. So here we can see a normal prostate with bright peripheral zone and normal transition zone in the center. And here is the example of benign prostate hyperplasia. And it's in coronal images, and here you can see in axial one. And in this case, sometimes it's very difficult to evaluate peripheral zone because it's compressed by the dermatose nodes of the transition zone. Here is an example of poor quality exam as well. We can see the peripheral zone slightly darker than it could be in normal exam where then we can, if we have poor quality exam, we can make a mistake and think that in peripheral zone we have, for example, prostatitis. So once more, good quality, high quality exam is a crucial one. And now the second thing what we are doing from starting evaluating prostate is evaluating prostate volume. How we must do this? We take sagittal and axial images and we measure from basis till apex. Then the second is from the anterior part to the dorsal part and from the right to the left. And then we have a formula and then we get a prostate volume, which is also should be a part of the radiologist report. And here I present you the main schema of PIRATS evaluation, and later I will explain all the signs that we evaluate in both zones. And at the first, I would like to say that it's crucial to know in which zone we have the lesion, if it's in periphery or if it's in transitorial zone. And according to this, we make our evaluation on all the images. We use all the images that I have mentioned is T2, diffusion, ABC, and contrast enhanced images. So at first, anatomical information is best evaluated on T2 images, and this is the dominant parameter for transition zone lesions. And T2 images we perform in 3 different platforms. It's axial, sagittal, and coronal. And we can see nicely represented prostate images here. It's PIRATS 1, it's absolutely normal transition zone and peripheral zone. We see bright and transition zone of mixed, usually slightly dark signal. If we see such wedge-shaped linear images or diffuse hypointensity, it's PIRATS 2 in periphery, and usually these signs represent previous biopsies, fibrosis from prostatitis, or some trauma or some other lesions that are not associated with cancer. But sometimes if a radiologist does not have practice, these lesions can be mistakenly taken for cancer. PIRATS 4, when we have circumscribed lesion, and the difference between PIRATS 4 and PIRATS 5 is the size. If we have 15 millimeters, it's 5. If you have small one, it's PIRATS 4. And if we have a lesion that does not includes into 2 or 4 or 5, so it's 3, when we don't know how to evaluate it. How we are dealing with transition zone? It's usually transition zone has a lot of adenomatous nodules, and it has a very mixed signal. So if we see nothing except heterogeneous nodules, it's PIRATS 1 in transition zone. And then we have a change that was made in version 2.1. It's circumscribed hypointense nodulus that we evaluate capsula in those nodes in order to say if it's 2 or 3, because if we see good encapsulate lesion, then we say that it's 1. and we score it 2 if we have a very dark homogeneous node with no capsula, or if we have a node with not full capsula. Then we taking into account and we use diffusion sequence in order to say if it's suspicious or if it's not. So if we have no change in other sequence in diffusion, we say that it's 2. And if we see changes in diffusion and corresponding ADC map, then it's 3. So this is the difference from previous versions that we are paying attention to transition zone. And what is important to see, not to miss in transition zone, it's such dark foci that are not circumscribed, and sometimes they are called like carporal sign. It means that they have no capsula and no clear form and contours. So again, if it's bigger than 15 millimeters, it's 5 in transition zone as well. Talking about diffusion and ADC map, these sequences are very special for MRI, and they correspond to cellularity. If we have cancer, we have high cellularity here. And this is the dominant parameter for peripheral zone lesions. And what is very important on ADC map, we have inverse correlation with Gleason score. So if we see a dark spot on ADC, then we can think that the cancer could be high Gleason score. Like in these images, for example, we have ADC not so dark, it's Gleason 3+3 in this case, and here we see dark one, and this is Gleason 10. So not always, of course, we have such a nice correlation, but a lot of publications say that it corresponds to Gleason score. How we get this diffusion images, what does it mean? This is maybe not for radiologists, but for others to understand. It means how water is going around cells, about water diffusion. When we have normal tissue, it moves free and freely. And if we have a high cellular density in case of cancer, we have diffusion restriction of water molecules, and this is why we get the bright signal on diffusion images and corresponding reverse images on ADC. This is parameters that are recommended on pirates for ADC calculation and for diffusion images. On contrast enhanced images, we evaluate how contrast is accumulating in all those lesions, and of course it corresponds to tissue vascularity. This is an example. We see a lesion on T2 image, and here we see a contrast enhanced image. Of course, while we're evaluating like positive contrast enhancement, then it should correspond other images on T2 or diffusion images, then it's positive. And if we see contrast enhancement in benign prostatic nodules, then it's not positive. Yes, for example, here you see dynamic prostate imaging of contrast enhancement, and we have to make a lot of images in dynamic sequence. It's about 30, where we evaluate how contrast comes to the prostate. Here we see non-enhanced image, and here we can see slightly that some parts of the prostate are starting to enhance. And for cancer, this is mostly important to see the fast enhancing lesion. Sometimes there could be benign nodes, and sometimes we can depict some focus, for example, like in left peripheral zone, like here. And if it corresponds, like here is contrast enhanced lesion, but if it corresponds on ADC, on T2, then it could be suspicious. Here you see all the sequences that we're using for pirates evaluation. It's T2, anatomical one, on which I remember you that we are trying to find some dark spots on transition zone or peripheral zone. Then this is diffusion and ADC. On diffusion bright, and on ADC it's dark. And contrast enhancement. This is the color scale put on these contrast enhancing. So resuming about pirates scoring, this is really important to see in which zone we have a lesion. And on T2 images, we evaluate transition zone, and on DBI images, this is of key importance on peripheral zone. Of course, later on, we evaluate all the images, but these sequences are key importance evaluating the lesions. And how it looks like to have the scoring system. I should remember you that it scores not the whole prostate, it's the lesion-based system. And if we have pirates 1, we have very low probability of clinically significant cancer. If we have pirates 2, it's low. In pirates 3, it's intermediate, and pirates 4 and 5 is very high, likely to have a significant cancer. Of course, in one prostate, we can have several lesions, and each of them can be of different importance. All the lesions should be measured on the map, on the sectoral map. And of course, we have first to find a lesion, then to locate in which zone it is, transition or peripheral zone. Then we have score it, report it, and schematically show on these schematic images. So let me remember what technique we use and what sequences we perform. We use more than 1.5 Tesla MRI machine. In the new guidelines, we use no endorectal coil. There should be no air in the rectum because it produces artifacts. For this, we use microlax enema 2-4 hours before exam, or we can use endorectal tube or catheter just to take out the gas from rectum. And the main sequences are free plane T2 images, diffusion, ADC, and contrast enhanced images. So how it looks like, what images we usually have. This is sagittal, axial, we have coronal images, then we have, these are T2 images, we have diffusion and corresponding ADC with bright lesion on DBI and dark on ADC. We have contrast enhanced, and here we see T1 images that are usually used for lymph node evaluation and bone metastasis evaluation. Now let's talk about diffusion. We have talked about T2, and on diffusion images we see, we look for bright spots in DBI. So firstly, we examine peripheral zone for DBI and look for something dark here. So if we see nothing, it's 1. If we see some kind, like we saw on T2 images, some wedge or linear-like signs, so it's 2. If we see something, but this does not correspond to some enhancing lesion, so it's 3. And 4 and 5, it's easy when we see a lesion on diffusion image that is smaller than 15 millimeters, it's 4. If it's bigger, then it's 5. And we see on ADC map the corresponding dark image. Now on transition zone, we see we also look like for diffusion images, not only on T2, but also on DVI. If we see nothing, it's 1. If we see some changes, but it's not clear diffusion restriction, is 2. If we see a clear sign, a clear bright diffusion restricted image smaller than 15 millimeters, it's 4. If it's bigger, then it's 5. And if we don't know where to put it, it's 3. Sometimes we have inadequate sequences. What we are doing at that cases, so we lean on those sequences what we have. So sometimes in peripheral zones, we have artifacts from gas, we have artifacts from coaxial prosthesis. So then we evaluate, we are scoring on T2 images. So of course, if we see a clear nodule, smaller or bigger, so it's 4 or 5, and sometimes it's really difficult to say if it's 3 or 2. So then we lean on contrast enhanced images, and if we see contrast enhancing ones, so sometimes if it's focal, not diffuse, sometimes we can say that it's 4, even without diffusion. And for transition zone, of course, we using the same signals if we have not good diffusion, so we lean on T2 images. That is pretty okay for us, because in transition zone, T2 is the key important. So now maybe this schema will be more easier for you. After explanation, here we have evaluation of peripheral zone and here of transition zone. So in case of we see nothing, it's easy. It's in diffusion 1 and it's pirate 1. If we see some wedge-like lines, so it's 2. And if we have something that we cannot really explain very easily, because it's a little bit bright on diffusion, a little bit dark, but it's not so dark as it should be, very important. And on T2 images, we see some lesion, so then we look at contrast enhanced images. And if it enhances, we make it pirate 4 lesion. And other 2 are easy. If we have on peripheral zone 4, on diffusion, so it's 4, and if we have 5, so it's 5. So maybe we have not so clear situation with 3, but there, if we have contrast enhanced images, it helps us. How about transition zone? We are looking on T2 images, on these anatomical ones, and for the help, we are using, of course, diffusion images. So if we don't see in any lesion, it's 1. If we see a nodule, remember about capsula. If it has clear capsula, so sometimes it could be even 1. But if we have very, very dark nodule, it's 2. And if we have not fully encapsulated nodule and it has some drop of in ADC or some bright signal on diffusion, so it could be 3. And if we have a carcoal zone not circumscribed, not corresponding to nodule, so then it's 4. And if it's bigger than 15 millimeters, it's 5. And usually these zones correspond to diffusion and ADC image changes. So this is Pirate's scoring system, and of course it could be easy to look at this scheme. Sometimes it's not so easy, and I will show you examples that where we really making some mistakes. And there's a schematic image of how to evaluate without adequate diffusion. Try to lean only on T2 images and use contrast enhancement. Of course, there are some situations where you don't have normal diffusion and contrast enhancement, and then of course you cannot score according to Pirate's. And without enhanced images, we will have some consensus discussion about these situations when patients sometimes refuse contrast or it cannot be performed. So then, of course, we take into account diffusion images, and sometimes it's quite enough. We will see, and it is called biparametric MRI, not multiparametric. So let me remember you that Pirate scoring system is individual risk for clinically significant disease for the lesion, not for the whole prostate. It's a lesion-based system. Of course, we should make some differential diagnosis between cancer and other benign conditions, such as benign prostate hyperplasia, hemorrhage, prostatitis, fibrosis after some procedures or inflammation, cysts, calcifications, and prostate atrophy. Of course, we're using all the sequences, but the dominant sequence in peripheral zone is diffusion, and due to the fact that the mainly cancers, about 75% of prostate cancers arise in the peripheral zone, so it is started even to recommend your start your evaluation of images from diffusion and ADC map. But of course, first you measure the volume of prostate, so you look through images in T2 sequences on sagittal, axial, and coronal. But then, of course, you can just look for some bright spots in diffusion. It's quite easy. Or even at first look for dark images, dark lesions on ADC. So here we have a lesion in the left peripheral zone, in the lateral part of the prostate, and it's Pirate's 5 because it's bigger than 15 millimeters. And then how we are doing, then we looking for schema, and we showing for urologists where it's located. How we are doing with transition zone, of course, at first we are looking again at T2 sequences, and transition zone is evaluated firstly in T2 images as dominant sequence, and suspicious lesions we're looking for something dark in transition zone. Then, of course, for corresponding on diffusion, ADC, and if we have, then we looking for contrast enhancement. So here we have a very clear lesion in the frontal part of prostate, in anterior transition zone, base and mid of the gland, and it measures more than 15 millimeters, so it's easy, it's 5, it's Pirate's 5, and we say that, and we put in the schema where is the lesion located. But it's not so easy in everyday practice because we have problematic areas. So sometimes when we have really big prostate or hyperplasia of central zone, fibrosis of central zone, sometimes it's very difficult to say in which zone there is the lesion. And areas in which we have a lot of problems, this is interface with central zone. Then we have a zone where seminal vesicles are going into the gland. It's the base of the gland. So we can say that in the base of the gland, maybe we are making most our mistakes. Then another thing is interface of anterior horn. Sometimes it's really difficult to say if it's the anterior horn of peripheral zone or is transition zone, or maybe the anterior stroma, and anterior apical region. I will show you some examples. For example, here you see central zone. It's in the base of the gland. And if you remember prostate anatomy, here there are ejaculatory ducts going through the prostate, going through this zone, and around them we usually have fibrosis, which gives us such a dark sign. And sometimes, if we don't know about this, it could be rather suspicious, especially when it's asymmetric. Dark somewhere in transition zone, when it's with hyperplasia, it's difficult to say, and we should be very, very careful by examining such lesions. Anterior stroma, it's also very dark normally, and sometimes it's really difficult to say if it's a cancer or if it's just fibrosis. So then we have a help from these contrast enhanced sequences, because sometimes even we can have diffusion restriction in these because of sometimes high cellularity, but contrast enhancement definitely says that something is wrong with this zone. So talking about contrast images, really sometimes we have discussion, as I have mentioned, about biparametric MRI, to use or not to use contrast. So if we have a lesion in the anterior fibromuscular stroma or the central zone, we should use contrast in order to differentiate from other lesions. So how we indicate on sector map? Of course, at first we measure and we indicate the index lesion, so the most aggressive lesion. The most aggressive is the biggest, or with lowest ADC, or with extracapsular extension. And maximum we indicate 4 lesions on Pirate's version, as it recommends. How to measure size of a lesion? There were some discussions in what sequence to measure. It is recommended to measure if a lesion is in peripheral zone, so on ADC map; if it's in transition zone, to measure on T2 images. But if it's poorly visualized on some sequence because of artifacts or some adenomatous nodes, so then you can measure in any sequence. And of course, you can measure and calculate lesion volume, which is calculated the same with the same very similar formula like we calculate the prostate volume itself. So how I am doing my everyday reading? As I have told you already, I am starting from, at first, of course, I'm starting from patient data. I look for PSA, I look for medical data, for referral information, and then I get my T2 sequences. It's sagittal, axial, sometimes coronal. I look for the general images of prostate, then I measure volume of prostate, I calculate density of the gland, and then I'm searching for suspicious foci. So I look through, mostly I'm looking at ADC first, if to be clear, and then I'm looking on diffusion, and then I look if I have some corresponding foci on T2 images and on contrast enhanced images. And if I have, then I report them and score them, and later on I put some markers on the scheme. After that, I'm looking for possible lymph nodes or other metastatic lesions in bones. And I'm looking again, I'm going back to rectum, to the urinary bladder, some other organs then can be evaluated also in this exam. What we should say about lymph nodes, we are used to 10 millimeter short axis diameter. That is important in other, for example, computer tomography or other MRI exams. Here, in Pirate's version, it is recommended to pay attention into lymph nodes that are measure more than 5 millimeters in short axis. And of course, we say which lymph nodes are bigger and which may be important for us. Seminal vesicles. Talking about seminal vesicles, the most what we find in seminal vesicles mostly is hemorrhage, and we have some patients referred just for this reason that they have the hemorrhage in ejaculation. But talking about cancer, sometimes it's not so easy. We have 3 types of tumor extension into seminal vesicles. It could be extension along ducts, it could be direct tumor extension, or it could be like metastasis, like metachronous tumor deposits in vesicles. And to find out that it's hemorrhage, it's quite easy. We use mostly T1 images with fat saturation, and we see hemorrhage as white spots very easily, like hemorrhage in prostate as well. But to say that seminal vesicles are changed because of cancer, sometimes it's not so easy. And here you see that in this schematic picture, it shows even not 3, but even more types of possible invasion to seminal vesicles. And sometimes this insertion of seminal vesicles into prostate is very very low. And then it is difficult to say where it's starting, especially cancer in the basis of prostate. And you know that in case of seminal vesicles involvement, we have T3B disease, and it's also very important to mention in your report if you see it. Neurovascular bundle, we can evaluate asymmetry, enlargement of this bundle, and of course it's very important also to its staging, of course, but evaluating prostate according to Pirates, sometimes we see these changes and we must mention them in our report. So, but it's very important to know about Pirates and multiparametric MRI. We will have consensus discussions about it later, so let's move on. So talking about neurovascular bundle, we can say that it's involved in some cases when we see extracapsular extension or contrast enhancing around the prostate. But not always it's possible. So in Pirates, it is recommended sometimes just to state that it could be involved when we do not see clearly that we have extracapsular extension and bundle involvement. And when there is more probability, then we can have extraprostatic capsular extension is when we have a long contact with capsula, when we have big tumor size, or if we have very direct spread to some other structures. What we have to say that in Pirates evaluation, we have really a great inter-observer variability. And in order to be experienced radiologists to evaluate all those images properly, we have to look quite a lot of images. It is recommended to look not less than 400 images and to do it every year. And of course, at start, it is easier when you have double reading possibility. I will show you some examples. Just to remember you, 2 times negative biopsy and growing PSA, usually it is an indication for MRI. And looking at T2 images, we see something dark on transition zone. It has no capsula, so it's suspicious for cancer. We have corresponding bright image on diffusion, dark image on ADC, and we have contrast enhancing image, so it's Pirates 5 and it's Gleason 7 cancer. Another images, here we have peripheral zone, dark, it's not so bright. Maybe the patient has prostatitis as well. Maybe he has fibrosis of prostate zone. But in the zone, we can depict something dark here. And the ADC map is very dark, it's small but dark, and it's very bright in contrast enhancing image. Because on DVI, we see we don't have very bright spot here. But we remember that if we have 3 on diffusion, it's dark, but it's not bright here, then we lean on contrast enhancing image, and we have upgrade to 4, so it's Pirates 4 lesion. And we should not lean only on one lesion. We should look through the whole prostate. This is the same patient, and this is some part of this lesion that we have analyzed already. But here in the front, we see another one. We see some dark spot, and it's somewhere here. Now it's not so easy to say if it's in the anterior horn of the right peripheral zone, or if it's in the transition zone. But in this case, we have signal changes both in transition zone and on ADC and diffusion. So then it does not change our scoring. But there are sometimes that our scoring can be different. So in this case, we say that it's another lesion on anterior transition zone and anterior stroma. How is with these images? We see benign prostate hyperplasia, and we can spot on ADC image some very dark spot. But if you look on diffusion image, of course, it's a little bit bright, but on T2, we see absolutely normal encapsulated benign prostate node, and it's just a little prolongating into peripheral zone. So, and it enhances on, but it's normally it can enhance. So it's Pirates 1, it's a lesion in the transition zone, and it's absolutely benign adenomatoous node. So normal anatomic structure that can be mistakenly taken for tumor, we should look through all the sequences, and if some lesions seemed to us very hypointense or very bright on diffusion, look at them again on T2 and on contrast enhanced images. So going through these pitfalls, I showed you already central zone. This is called like mustache sign. If you see in the both sides possible some dark lesions, dark zones, wedge-like, so this is fibrosis of central zone. And in coronal, it has a name of teardrop sign. If you look at these maybe suspicious zone on axial images, then on coronal, if you see it's very symmetrical, so then it's central zone. Ejaculatory ducts in the periphery also make us some problems because sometimes in the midline they can look like some dark lesion. And how to say that it's not a cancer? Because sometimes it has even some signal in diffusion, but it never will have contrast enhancement. So here we have to look at contrast enhancing images. Sometimes we have prostate capsular insertion into midline. It's again, it will not have contrast enhancing. Prostatitis, usually we can differentiate it from cancer on diffusion and on ADC images. It has no low signal on ADC, but it has contrast enhancement. But usually, luckily, it's diffuse, and so we can differentiate prostatitis from aggressive cancer lesions. Edematous ectopic nodules, which are prolongating from transition zone into periphery, and sometimes it's really challenging to know, and we have to stick a needle into it to know if it's not a cancer, because it enhances, it has drop on ADC, and if we cannot say it clearly, maybe it's a good reason to make a biopsy for differentiation. Local thickening of surgical capsula between transition zone and peripheral zone. Sometimes it also can be mistakenly said that it's a cancer. It has no contrast enhancement. Granulomatous prostatitis, one of different diagnoses to make, and it mimics really cancer. As we had in our practice, usually it does not give such a low ADC value. So, and it looks sometimes more diffuse than local lesions. But usually we should make a biopsy in order to have a correct diagnosis. Anterior stroma hyperplasia. It's difficult to differentiate, and mistakes are made in this case. Let me remember you again, contrast enhanced images can help. So in conclusion, to differentiate between cancer and some anatomical structures, as you see, contrast enhanced images help us. And this is discussion about multiparametric versus biparametric. If you know anatomy really well, and if you are experienced radiologist, maybe it could be possible to use biparametric MRI, but I think we'll talk about it on our discussion. What must be taken into account on pirates-free lesions? Pirates-free, it means that you don't know really what's happening with this patient. So all the recommendations say that if clinically it's suspicious, so the biopsy could be performed, of course, and systemic biopsy if you do not have clear lesion. And in these patients also MRI is recommended to repeat in 9-12 months. When our multiparametric MRI is negative and false negative, usually when we don't have really clinically significant cancer or big volume significant cancer, and if we have low-grade cancer, so then it is stated that we can have false negative MRI. What radiologist needs to know before MRI? It's PSA. We should calculate PSA density, and it's good to know previous biopsies, data of biopsies, Gleason score. If we have such, if a patient uses some medication, if we have treatment on, because it's really important evaluating MRI. And what radiologists should include into a structured report. So as I have mentioned, is PSA, prostate volume, density, then we should mention every lesion, maximum of 4. And say where the lesion is located. And again, we scoring every lesion on PYRAX score. And if we have real cancer, we can say TNM. And if we have follow-up, we compare with previous MRI. So when we have a lesion, in structured report, we make a conclusion, which pyrite score it fits most, and we can say possible histology, of course. If we can do this, if we see very, very low ADC value, we can say that we think of very aggressive cancer. And of course, in conclusion, as I have mentioned, we should report staging if we can. Limitation of exam, as you have understood, it's rectal gas, and if we have high field MRI, 3 Tesla, so these artifacts are even more. And we have bowel movements, we have patient movements, we have prosthesis artifacts, obesity. Sometimes it's really difficult to perform and to have a high quality exam. So let me remember the main factors while determining pyrites, that we use T2 sequences and diffusion sequences. T2 is here important for transition zone, diffusion for periphery. And of course, we add contrast, and contrast is really sometimes important in differentiating difficult lesions. Let me remember you that lesion location is important, because you have to say in which zone it is, and then it would be easier for you to score the lesion. And pay attention to problemic zones like central zone, intraprostatic seminal vesicles, anterior horn of peripheral zone, apex. For example, this case, I don't know if you see the lesion, you can test yourself. I can depict some dark spot on ADC, and on T2, it corresponds to some nodule. It is difficult to say if it's on transitional zone or if it's in the periphery, in the anterior horn. And if to think that it's an adenomatosis node, so then it could be some question mark, but I think that it's more in the anterior horn, but of course it could be a discussion. And one more case just for you, it's we can see some bright spot in peripheral zone, and it's rather difficult to say here if we have real lesion or if we have not. It's somewhere in the middle, but on ADC we have a lesion that is also a little bit lower than other tissues, so we can say that it is a lesion. We can try to biopsy it. It's very small, so possible it's better to do some fusion biopsy or some in-core biopsy. And very, very few words. It's not pyrites, but an addition to pyrites 2.1 version. It's about how to deal with patients when we have observation, follow-up, active surveillance in patients with Gleason 3+3 cancer, and when we follow up and doing MRI. So it is recommended to score them according precise. It means that if we have a resolution of previous features, we say that it's 1. When we compare with previous and we have reduction in volume, so it's 2. If it's stable, it's precise 3. And if we have disease progression, it's 4 or 5 if we have definite radiological stage progression, it's like metastasis or lymph node metastasis. So I think that later it will go into pyrites maybe 3 or 2.2, who knows, into later guidelines, but it's just recommendation to look for this paper and to see how it is scored. And another important paper that was published recently, it's about how to report local recurrence. It's called not pyrite, but PIRR, It's again international consensus, and later I think it will be put into guidelines because Professor Barnes is also involved in it. How to evaluate patients' MRI after radiotherapy or radical prostatectomy. It means that later I will show you some examples. For example, there is our patient after radiotherapy when we have some drop on ADC and new lesion enhancing contrast. So we just saying that it's recurrence and that's it, but it's easy. And if we have some not so easy changes on MRI, it is recommended to use very similar system to PIRATS. So it's 5-point assessment scale where we see the likelihood of recurrence. And the main thing to know is where the lesion was in the first images. So of course, if we see nothing, it's 1. If we see some wedge-shaped or diffuse hypointensity, it's 2. It's very similar to PIRATS. If we see something, but we do not really know, it's 3. And if we see a lesion, but it does not correspond to previously known cancer, so it's 4. And if we see on the previous cancer place, it's 5. So the only difference. It's just for you to know. It's not included in the last version of PIRATS 2.1, but you are welcome to know about these new papers. And after radical prostatectomy, it's also very similar scale. You don't have cancer at all, but here you see, of course, you must have enhanced images in these patients after radical prostatectomy. You should look for normal hypointense anastomosis. And if you don't see any abnormalities here, so it's 1. If you see diffuse thickening or very moderate signal changes, it's 2. If you see something, but you have not enough for true cancer, it's 3. But sometimes, of course, you can choose to perform a biopsy in some patients if you have some PSA raising in this case. And if you have marked signal changes, but not at the previous cancer site, it's again 4. And if you have signal changes there where you have had the cancer before operation, so at the same site, so then it's 5. So concluding all the presentation, so what is important in prostate MRI? Firstly, I should say it's a high quality exam. You cannot make a good diagnosis on bad images. That is really very important. Patient preparation. We recommend to make enema before the exam, but some patients, especially who have obstipation, some chronic obstipation, they make this enema, and then we have a lot of peristaltic artifacts, motion artifacts. So sometimes it's not good solution. Sometimes it's better to have a gas tube for such patients. Then it's referral information. It's important for all the urologists who send the patients to MRI. Please say what is really important about this patient, what you want to know about him from MRI. And for us, for radiologists, the main thing is to see the lesion, to localize the lesion, in which zone, and to score it according to PIRATS. Very important is to have feedback from your urologists, to participate in MDT meetings, because another way you cannot be a good radiologist. And of course, this recommendation to get 400 cases per year. Of course, know your pitfalls. And I should recommend these courses at Professor Barnes' clinic in Netherlands, of course, if you would like to gain experience as a radiologist. It's really worth to know about them and to participate. So thank you for attention. And sorry for these technical issues because of the internet.
Thank you, Ruta, for great presentation, great lessons. Because after your lesson, I think that I know everything about MRI. But actually, it's not. It's not so easy. Am I right or not? Actually, it looks like it's very easy on the graphical issue to have that. But still, on when you start working, you start finding these lesions. You always think, am I right or am I not? And sometimes you need a lot of experience to do MRI reports.